We are back, and we are joined now by Dr. Uche Blackstock, physician, founder and CEO of Advancing Health Equity, and author of Legacy: A Black Physician Reckons with Racism in Medicine. Dr. Blackstock, thanks so much for coming on this program.
Thank you so much for having me.
Sure. I mean, today's the first day of Black History Month, so it's great to have you on to talk about this ever-pressing issue of these massive disparities in healthcare and health equity along racial lines that are as persistent as any piece of systemic racism in this country. And I want to get to that in a second, but your book also has so much of your personal experience embedded into it that I think is really important for people to understand the legacy of your mother, the work that you and your sister do, and how that kind of informs why you felt so inspired to do this kind of work. If you don't mind talking a bit about that.
Sure, absolutely. The name of the book, Legacy, actually, has a double meaning, as you allude to. It's, the legacy of being a second generation Black woman physician. My mother, my twin sister Oni, and I are the first Black mother-daughter legacy from Harvard Medical School. And that was that happened in 2005. So, we're still making history in ways that, we can celebrate, but also seem a little bit inexcusable. But my mother was born here in central Brooklyn, where I live now, under very different circumstances. She was born to a single mom on public assistance. They moved around a lot. But my mother was very, very curious and had a strong work ethic, and was lucky enough to be the first person in her family to go to college, and had a chemistry professor there who encouraged her to apply to medical school, which was something she hadn't really thought about. And so she applied to medical school, got into all of her medical schools, and ended up matriculating at Harvard Medical School, where she obviously felt like a fish out of water. There were kids in her class whose parents had written some of the textbooks they were using. But one of the things about my mom is that, she could have gone anywhere after Harvard Medical School, but she came back to New York City. She trained at Harlem Hospital, and then she ended up practicing in the very same neighborhood that she grew up in central Brooklyn, caring for her family and neighbors. And so that was a huge lesson that my sister and I learned from her, is that, you go to these prestigious institutions and you come back and you work in service to your community. So the work that my sister and I are doing now, the health equity advocacy work, we both have consulting firms where we work with healthcare organizations around bias and racism in healthcare to close the gap in racial health inequities. But really that legacy is continuing the work that my mother started, when we were younger, where she would work with other Black physicians to organize community health fairs and connect patients to the services that they needed. Then it didn't have this sexy term health equity, but she was doing health equity work, and she was really looking at her patients in a way where she was thinking about the social and political contexts in which they lived, worked, loved, and prayed. And so that's the kind of holistic way I think about how we should care about our patients.
And your mother sadly passed away from leukemia in her late 40s. What was that experience like for you? I mean, of course, it's completely tragic, but to go through that kind of intense medical crisis as you and your sister and your mother have this kind of heightened awareness of what it means to be a Black woman getting this kind of care in America.
Yeah, no, absolutely. I mean, we were 18 years old when she was diagnosed with acute myelogenous leukemia, and she really, she took such great care of herself. It really was a shock. She was only 46 when she was diagnosed, and 47 when she died, a year older than I am right now. But at the time I was so young, I didn't even really understand, kind of the risk factors that she had, that the fact that as a Black woman, the kind of leukemia she developed was very, very rare. And it really was as a practicing physician that I started really kind of relearning sort of all the educational gaps in my my training. And I did some research for the book, that my mom grew up in neighborhoods in central Brooklyn that were Superfund sites, that there was, toxic dumping. And when my mother was getting treated, we went and got a second opinion at Dana-Farber Institute in Boston, and they told her it looked like from her chromosomes. She had been exposed to radiation at some point early in her life. And so that's what I write about in Legacy, that, there was a chance that my mother was exposed to radiation because, she lived in poverty in these neighborhoods where, toxic dumping and exposures happened. And that could have been implicated in why she was so young when she was diagnosed with this disease and ended up dying prematurely.
And I mean, the the environmental racism aspect of it, I want to get to as well, because that's so key to understanding many of these current kind of racial disparities. I mean, Flint, Michigan obviously comes to mind, but there are countless Flint, Michigans across the country, and Superfund sites, and all of those things that you discussed there. But something that really struck me in your book was that the percentage of Black physicians was actually higher in 1910 than it was in 2008, nearly 100 years later, when this was tallied. And you talk a bit about this thing called the Flexner Report in 1910, which seems very much at the root of this very low percentage of Black physicians in this country. Talk a bit about what that was and how
Sure.
we're still living with that.
Yeah, and I should just give context. Like, growing up, I thought most physicians were Black because that's who I was surrounded by when I was younger, by my mom, by my pediatrician, all of the women physicians that she worked with in the local organization. And so when I got older, I was like, wait a minute, our percentage is really that low. And it really was, as a practicing physician, again, that I was on this journey of trying to unlearn and learn those educational gaps. And so one of the, discoveries that I made was this Flexner Report that actually was, commissioned by the American Medical Association, which is one of the oldest and largest organizations of physicians and has its own kind of horrific history with bias and racism, and the Carnegie Mellon Foundation. So they commissioned an education specialist named Abraham Flexner, who also in his writings had very, very racist ideas about Black people and Black students. But they commissioned him to go around to the 155 medical schools in the United States and Canada, and to hold them up to the standards of Western European medical schools, and in the US, specifically to Johns Hopkins. At that time, there were 7 historically Black medical schools, but this report led to the closure of 5 of them, leaving behind Howard and Meharry medical schools, which are still open to this day. But obviously, because of the legacy of racism, of generational wealth, those Black medical schools did not have the resources, did not have the equipment, did not have all of the criteria that were needed to fulfill these recommendations that Flexner put out. And so it was interesting. In 2020, there was an article in the Journal of the American Medical Association that calculated and estimated how many physicians those Black medical schools, those 5 schools that were closed, would have trained. They estimated that between 25,000 and 35,000 Black physicians would have been trained in those medicals had they remained open. And when I read that, I cried. I cried because I thought, what a tremendous loss to our communities, what a tremendous loss to our patients, the hundreds of thousands or millions of patients those physicians would have treated, the students and trainees they would have mentored, the research that would have been done in Black health. And so I thought it really was important for people who read Legacy. It's really for a broad audience to understand why in 2024, even today, why the numbers of Black physicians are so low. And it has a lot to do with the Flexner Report. I also should add that, the recent SCOTUS decision on race-conscious admissions, I think, could have a very similar ripple effect as the Flexner Report, because it will impact, the diversity of who's admitted to pre-med programs, to medical schools. So I think unless these academic institutions try to find ways to make sure they maintain a diverse student body, we may see a similar impact from the recent SCOTUS decision on Black health and Black communities.
What were some of the reasons that the Flexner Report gave for shutting down these medical schools?
Right. So So essentially, there were a few areas that they said all medical schools should have a certain standard for. So admissions criteria, like certain types of laboratories, certain numbers of physician scientists as faculty. So, obviously, Black medical schools,
Right.
probably, didn't have a lot of physician scientists or laboratories. And I think that like to use like the same standards for them as predominantly white institutions that had a totally different set of or amount of wealth and resources was unreasonable. But he suggested that Black medical schools were putting out underperforming, physicians and medical students. But he was using these very stringent criteria that I don't think was necessarily fair to compare Black medical schools to, and doesn't necessarily mean that those schools were indeed putting out poorly qualified physicians. I will say even now, medical schools go by, use MCAT scores and GPAs, and we know that, the MCAT, which is the exam you take for to get into medical schools, that is impacted by socioeconomic status. Like, if you are right, so if you're right, yeah. So if and that doesn't necessarily predict if you're going to be a good doctor, right? So there's so many other ways that you can predict or encourage, people to be good physicians that don't necessarily, rely on scores and MCAT scores or GPAs. Like, we need a really more holistic idea of what it is to be a good physician, because we actually already see that if schools are using these standards, why do we still have these racial health inequities today, right? Like, you would think everyone would be getting the best care.
I mean, let alone the fact that going to medical school, if you don't have the money, you're going hundreds of thousands of dollars into debt immediately. And then
absolutely
the compounding effects of that are, okay, so the kind of advocacy that you do, right? Maybe if you're a Black medical student who's in that amount of debt, or just a medical student who's in that amount of debt, and you want to be more community focused, you're probably going to go to a more high paying job to pay off your debt. And then there's this brain drain in poorer communities.
Exactly. And we see that already. We see that in specialties like primary care for adult and pediatrics, because of our current, for-profit health insurance system that reimburses primary care physicians at a lower rate. And so we have a lot of medical students going into subspecialties like dermatology or plastic surgery or orthopedic surgery, where they can get compensated more. They're able to pay their loans back. And so there are some medical schools that are becoming tuition free or giving grants to students. And I think that really the obligation of medical schools really should be to prepare physicians to take care of a diverse patient population and to work in underserved communities. So there should be incentives given to students to work in, marginalized and underserved communities, like many Black communities in this country. And there simply are not, there are some, loan repayment programs through the federal government, but I think it's up to private institutions also to make sure that they are training medical students to work in those communities, as well as applying for primary care and like primary pediatrics, geriatric specialties.
Right. And the other piece that I also want to touch on as well is the fact that, on its face, you could maybe draw some more simplistic conclusions about Black medical care because of just socioeconomic status, right? Because there is this massive wealth gap that has persisted for so many years or centuries and decades, that is the sole root. But you cite a bunch of really high profile examples, the most recent one being Serena Williams, speaking about how she was not taken seriously when she had symptoms that were, I think, like her previous blood clot during her pregnancy, if I'm not mistaken.
Yes, correct.
And she was calling attention to this, and she almost died in her pregnancy because of that. And she has so many resources. She's a millionaire. She's one of the greatest athletes in the world. So it's not just socioeconomic status. It's also just like Black pain's not taken as seriously, and Black female pain is not taken that seriously.
Yeah, no, exactly. One thing I always quote is like this idea that, here I am as a Black woman physician with a Harvard undergrad degree, a Harvard med school degree, but I'm still 5 times more likely than my white peers to die of pregnancy-related complications. And you would say, okay, wait, so why is that? Like, why is that the case? I have access to, insurance. I should have access to quality care. But the other piece of it, in addition to how racism impacts what we call the social determinants of health, like housing, education, just basically depriving communities of resources that ultimately impacts health. The other part of it is what happens when Black patients interface with the healthcare system and health professionals. And this idea that it really doesn't matter what your socioeconomic status is that, often our concerns are minimized or ignored or dismissed. And so we see that actually a lot, regardless of socioeconomic status. And, I think most health professionals would like to say, no, I treat all my patients well. I treat them all the same. But unfortunately, what we're seeing is that really is not the case. That exactly, you mentioned this whole issue of pain and pain inequity, and that how often, there was a study in 2016 out of UVA that showed that medical students and residents with 2 mock cases, the only difference was the race of the patient. They consistently scored the Black patient's pain lower. Yep. and gave the patient less pain medication. So that's 2016. So I always say in the book, because there's a lot of history in it, a lot of these myths about Black people being biologically different, not feeling pain, are deeply rooted in the history of our country's racism, Jim Crow, and it persists today in our healthcare system.
I cite that exact example a lot because it's the one that sticks in my mind. I believe that study also in that survey of those medical students found these really racist tropes that they still like, that Black skin is thicker than white skin, for example.
Yes, I know. Yeah, I was like, I didn't want to answer your question too long, but yes, I'm so glad you brought that up. So the authors like made up these myths, right? Yeah, like Black people's skin are less sensitive to pain, or Black skin is thicker. So and they found that those medical residents and medical students who were more likely to believe in those false myths were the same ones who were more likely to score the Black patient's pain lower and undertreat the Black patient's pain. So I like to say this, that like health professionals are no different than anyone else who lives in our country, that they are also absorbing this cultural messaging that we have all around us in the media, in books, in all different places about anti-Blackness and how Black people are somehow different. And unfortunately, very unfortunately, that actually impacts how we are caring for patients.
Right. I mean, it's amazing, and how that myth, how those same folks, medical students, despite going to undergrad, having this understanding, they buy into that, and you just show how deeply rooted it is.
Right. And can I add one thing?
Yeah.
So, I talk about in medical school, like explicitly or implicitly, sometimes, we're taught that there are differences. Like for a long time, there was a race correction factor that was associated with kidney function. There was a different set of normal values for Black patients and non-Black patients. Like if you go into the electronic medical record system, you would see different ranges. And that was based on old myths that Black people had more muscle mass, and that correlated with a different set of kidney function. And so actually what that led to is actually Black patients having a delay in being referred to for specialty kidney care and being placed on transplant lists. So that race correction factor, a lot of kidney groups have been working towards getting rid of that. But we see how, these differences based on these myths actually end up harming Black patients.
And it essentially boils down to race essentialism, right? It's
exactly.
This idea that people are inherently different biologically in some way based on race. I'm wondering how you feel, and I don't have the knowledge really to go to make an assertion here, so I'm going to ask for your expertise on sickle cell, because there's a real lack of research and treatment, is my understanding, for sickle cell, or an analysis into the potential connection with past instances of malaria. That's something I had read previously, but I'm curious what your take is on that kind of debate.
Oh, sure. And I think I would preface this by saying, like, when we see these poor health outcomes, even among patients with sickle cell disease, really what they are it's the impact of racism, right, through practices and policies, and not race. So, for example, with sickle cell disease, even it's a gene, it's an inherited disease, right? So it's based on a gene. So it has, there's geographical ancestry related to it. It's not race. And one thing I talk about in the book is that there are people from all over the world that have sickle cell disease. A lot of them are from sub-Saharan Africa, but a lot of them from the Mediterranean, from India, also have the sickle cell gene. And the issue is that in the United States, most people with sickle cell disease are Black. Right. So 100,000 Black people in the United States have sickle cell disease. And so because of that, it's been racialized as a Black disease. So even though the disease it's been discovered over 100 years ago, and yes, it does have a protective factor for malaria. Like, there's a reason why people in those different parts of the country, I'm sorry, of the world rather, have this inherited gene. It's supposed to be protective against developing malaria. But at the same time, because it's been racialized as a Black disease, in the United States, we have seen a lack of research into therapeutics, lack of funding going into developing sickle cell centers of excellence, like we have for other inherited diseases like hemophilia or cystic fibrosis, which primarily affect people who are racialized as white. And so because of that, we see a lot of patients with sickle cell disease coming to the emergency department because there is not a system in place to care for them appropriately, so that to prevent these ER visits, we see them in the ER. And what happens is they get stigmatized. They come in with pain crises and they get stigmatized as drug seekers, like they're seeking pain medication, and they get characterized as people who are, you have to be suspicious of, who are just there because they're addicted to pain medication. And really, what it's a result of we don't have a system in place outside of the ER because of the lack of funding to care for these patients. And so it's like almost like it's compounded. It's like these issues are compounded on each other, and so. That's the experience. I talk about this patient I had with sickle cell disease in my book, who just, came to the ER so often. And we saw so many patients like that in my residency, which is based in a mostly low income, working class Black neighborhood.
And the lack of preventative care is also going to compound anything else that comes up. And
exactly.
I guess that brings me kind of to where I wanted to conclude, which is maybe our most recent example of extreme medical racism and lack of care for Black people in this country, which was the COVID pandemic, and who bore the brunt of the pandemic, who was asked to make sacrifices to keep the economy going, and who was not.
Right.
I know that was a big part of your inspiration for the book. If you could talk a bit about that, your experience as a doctor during that time.
Yes, absolutely. I had made kind of a career transition at that time. I moved from ER to urgent care in January of 2020. And then March happened, and I was, working in Brooklyn, New York, in the epicenter. And I was at an urgent care where we saw a very racially diverse patient population, but literally within days, I saw a quick shift in who I was caring for, mostly essential workers, service workers, mostly Black people and people of color. Most of my white patients I did not see. Many of my patients worked for the MTA, the subway and bus service. They were coming in with COVID symptoms. And I remember thinking, even before the pandemic hit New York City, seeing the risk factors of high blood pressure, diabetes, obesity, asthma as risk factors for people who do worse when they get COVID, I said, I'm so worried about our communities, because I know our communities carry a higher burden of those chronic disease because of systemic racism. And so I actually wrote an op-ed before the end of March about what I was concerned was going to happen. And of course, it did happen, but it just kind of exposed already the very deep fissures that we have within our healthcare system as it relates to access to healthcare, as it relates to, employment. Like, we know that people in essential jobs or as service workers, low paying jobs, were more likely to be interfacing with the public and exposed to the virus, and also less likely to have employer-sponsored, especially service workers, employer-sponsored healthcare. So again, even more at risk. We know that people of color were more likely to live in multi-generational housing. Again, more at risk, more likely to take public transportation. So I thought it was really it was very unfortunate, though, but to show like this how the pandemic really to use it to connect the dots to show how systemic racism impacts those social determinants of health and leaves our communities so much more vulnerable for when a pandemic hits.
We had Garrett S. wrote in, as a pediatrician listening during my lunch, I love this interview. I'm trying to messaging with some of these same points, but Dr. Blackstock keeps beating me to it. Bravo. So that's
Thank you.
One of the messages from a fellow doctor. Dr. Blackstock, I really appreciate your time today. We will put a link to your book, which is called Legacy, A Black Physician Reckons with Racism in Medicine, in the description wherever you're listening to this or watching, and at majority.fm. Thanks so much for your time today. I really appreciate it.
Yeah, thank you so much for your thoughtful questions.
Oh, thank you.